All right, and welcome to this fourth in March forum focusing on COVID, the Science Festival for most of you who, if you don't know, is the celebration of Maine science. In the before times, we met for a 5-day giant celebration of Maine science by the people who do it. In the last 2 years now, well, last year we canceled with the ensuing pandemic, and this year we're also not able to meet in person just yet, so we're doing these online forums. We are thrilled to be focusing on COVID in Maine. Not thrilled, but you know what I mean. Happy to talk about the science that has been part of helping address COVID in Maine for the past year. And I am over the moon to have with us LuAnn Ballesteros from Jackson Laboratory and Nesin from PCHC, both of whom are longtime friends of the festival. And who have not entirely clear to me, almost always said yes when I've asked them to do something, even though they are swamped beyond belief. So I'm deeply grateful to both of them for that. Just very quickly, LuAnn has been with the Jackson Laboratory since 2015. She has been one of the people who has been really instrumental in helping me figure out the best people at JAX to speak to make sure we focus on their work, and has never flinched when I've told her I don't want to talk about mice, I want to talk about all the great stuff that the mice help them do. So I've always been grateful for that. And Nesin is at the Penobscot Community Healthcare. I don't actually even, your chief medical officer, last I knew, I don't know if that's still your title, but Noah has also been a huge friend of the festival and has helped us talk about all sorts of things from opioids to now what he's going to talk about with vaccine distribution. So we're going to jump right in. If you want to save your questions, we're going to have both presentations. LuAnn's going to talk about public health aspect that Jackson Laboratory has been doing, and Noah's going to talk about vaccine distribution and how it's been addressed in Maine. Save your, just throw your questions in the Q&A in the chat. Actually, the Q&A would be great. We've got that monitored. We'll try to get to all of them. And before I go any further, we are able to do these forums entirely because of the support we've gotten from the Jackson Laboratory and Bioscience Association of Maine. So they have let us do this, and my goal is by the end of this, if not by the end of this session, by the end of next week, I will have mastered Zoom webinars. So that will be because of the support we've gotten from these folks. So without any further ado, I'm going to hand it off to LuAnn, and she's going to cover public health in the way that JAX has really stepped up. And just as a little preface, I think this is an untold story, like many things that have happened in the last year with the pandemic, because there's been so much coming at us. So I'm thrilled to have you talk about what Jackson Laboratory has done for public health and testing.
Great, thanks so much. So at the risk of repeating myself, I just said this when we were on the practice session, but it is worth repeating. I want to thank Kate, because really what Kate does with the Science Festival is critically important to Maine, to the STEM environment that we really need to continue to focus on, and her friendship and partnership, not just to JAX, but across the STEM fields and with the general public, has been terrific. She does a fabulous job. So thank you for this opportunity. I also want to say, she just talked about how I always find her terrific speakers, and today might end up being the exception. I'm Vice President for External and Government Affairs, and it's been a really interesting year for me because I have done my government affairs work has been very different than anything I've ever done in my entire career, and certainly in the 15 years I've been at JAX. Basically, it's I've had a steady diet of COVID testing, at least it feels like it, for both Maine and Connecticut, a little bit in California where we have facilities, but also now it's moved into the whole vaccination phase, but Noah's, we'll talk more about that. At the Jackson Laboratory, we use WebEx far more than we use Zoom. And so I want you to bear with me because I am about to endeavor to share with you a video, and it may be clunky, but I think it helps lay the groundwork for what JAX is, who we are, what we do, just to give you the kind of a quick overview. And so hold on, we're going to give this a shot. I've tried it twice and it's been effective, so bear with me if it's clunky. I think I'll get there.
Imagine
Can
a
everybody
future
hear it
where
and see
you can
it?
predict when any disease might occur,
You're good. You're good.
treat
Good.
any disorder in real time, and even prevent diseases from ever happening. This is the future of medicine, one where we will be able to create a precise roadmap for a disease-free life. As an independent, nonprofit research institute focused on genomics research, JAX has nearly a century of experience, the cutting-edge tools, the award-winning researchers, and the foresighted vision to make this exciting future possible. We are an extended family of scientists, employees, friends, and donors who are determined to unravel the mystery of human disease to find cures. In fact, at JAX, cures are in our DNA. We were the first to describe stem cells. We developed the techniques now widely used for human fertility treatments. We performed the first bone marrow transplants. We unlocked the capability for today's organ transplants, and 26 Nobel Prizes were awarded for discoveries based on our models. These and many other JAX discoveries continue to save countless lives around the world, and we're driven to do more. We are ready to craft predictive tests, guide lifestyle changes, uncover new prevention methods, and identify new therapies. We are ready to change the face of human health for you. Join us today.
I feel so accomplished. I actually pulled that off. What I like about that video is it gives you a little bit of an introduction into one of the really important things that JAX does that lots of people know us for. And Kate touched on this a little bit, but that lots of people within the organization think we talk too much about, and that's our mice. Because at the same time that we have our mouse models that we sell to 57 countries in the world and multiple millions of mice every single year, we also have research scientists who use those mice to find medical discoveries, but we also have a really robust education program. So one more slide, I want to share a slide with you that just sort of gives you a little bit of information about JAX, specifically in Maine. And so I'm going to try to share again this presentation. There we go. Can everybody see this?
I think you need to hit screen share.
Oh, phooey. Figures, huh?
That should do it. Yep.
Showing up now. So I'm sorry, it's not in the right exactly format it's supposed to be in. How about this? Arg. Stay with me, folks. Stay with me. There we go. All right, this is the slide that is most important to me. So in Maine, we have 1,700 employees. We're the 15th largest private employer, and aside from the hospitals and the academic institutions, we're actually the largest nonprofit. Our average new salary hire amount is $60,650, and in the fine print you can see that the average in Maine is $46,000. We had 239 new hires in Maine, and just to let you know, this data is based on 2019. We're working on our 2020. We're always a year behind 2020 economic impact report now, but the thing that excites me about the new hires is that about 15% every year, between 15 and 20, actually come from outside of Maine, and they're young people. You know, their average age 32.9, and a lot of them bring families. This matters a lot if you pay any attention to the demographic information that comes out about Maine, because we're in a panic all the time about a flat demographic in terms of growth. We're the oldest state in the union, blah, blah, blah. You've all heard it. But our employment growth is from 2013 to 2019 is 22%. That means that we've added employees to the Jackson Laboratory at a rate that's 3.7 times greater than the average rate in Maine, and our payroll has increased 1.7 times faster than other payrolls, the average in the state. We have employees in 84 different municipalities representing 12 of the state's 16 counties. I actually live in Glenburn. I've got a 90-minute commute each way to get to the lab. I've been doing it for 16 years, except for this past year, which I haven't missed the drive. I have missed the colleagues, but, and then Jackson invests about $75 million or more every single year in capital expenditures in Maine. And those expenditures create 581 indirect jobs. And then our buildings, you know, most of you probably know we have a facility in Bar Harbor that's significant on 169 acres. It's 1 million square feet under roof. And then we have our new facility in Ellsworth. We have about 350 employees there, and that's a 343,000 square foot building where we do production. So I am going to stop sharing that for now and chat with you a little bit about how we piece these things together. So our director, Ed Liu, is an MD. He's also a research scientist. Came to the United States to San Francisco when he was 5 years old. But for a period of time in the early 2000s, he was actually in Singapore running a genome institute. And as it turns out, while he was there, the first SARS epidemic, worldwide epidemic, started, and Ed was in charge of leading the SARS epidemic for Singapore. So when COVID first started becoming just something that was intermittently on the news and no one had any idea that it would be a pandemic, Ed began to worry about it being a pandemic, and he began talking to all of us on the leadership team very early on, not wringing his hands, but concerned, greatly concerned about the US's capability to respond. And he was saying as early as late January, early February, we're going to need to test. We're going to have to test. We're going to have to test everybody. We're going to have to test frequently. And it was basically internal to Jack's, all hands on deck. We sort of stopped doing everything except figuring out how do we keep the Jackson Laboratories employees safe? How do we lend our assistance to others, the state, anyone that needed it, basically. And fortunately, about 7 years ago at our facility in Connecticut, we actually became CLIA certified. So we have a clinical lab in Connecticut where we were doing, for the most part, tumor testing for organizations, hospitals, et cetera, in the state of Maine. And through our Maine Cancer Genomics Institute, which is at the hospital in Augusta. And so we just ramped up. In like a 3-week period of time, we went from 14 employees at our CLIA lab over the next few months to 94 employees, which is where we have been since we first started doing testing. At the time, the state of Connecticut was able to do about 25 tests per week at their Department of Public Health, and the state of Maine was in a similar vicinity at our CDC in terms of doing COVID testing. You all lived it along with everybody else. It was, you know, where do we get the swabs? And come to find out, how great is it that Maine's the only domestic producer of nasopharyngeal swabs and anterior nares swabs, and that's a fantastic story. But we really ramped up. We started doing outreach. We ended up helping the University of Maine through the entire semester with daily testing of all of the folks that were at the university, both students, faculty, staff. We made sure that Maine Maritime Academy was able to do their fast cruise so that their students that were seniors could graduate. We're still testing, and we did all last semester, but we're still testing with the University of Maine. With Maine Maritime Academy, and likely will do so right straight through this semester and probably do surveillance testing. But we also did, and let me share again the slides so you can see the different organizations that we worked with and continue to work with. So this is what those numbers look like. So we are doing testing with Cary Medical Center up in Caribou. They're small numbers, but they come in every day. We did testing with the University of Maine until they got their own system up and running, which is awesome for them. Integra Health, Island Nursing, Maine Maritime Academy, Maine General. You can see the numbers here, but we really did and continue to do. It's super helpful for those organizations and for basically public health in the state of Maine, that there's an option that isn't a commercial option like Quest or whatever, and the state's just not equipped to do all the testing that needed to be done. So the other piece of what we did at our CLIA lab that was a differentiator, not just for JAX, but for all of the testing facilities, there were times in the first 4 or 5 months of the pandemic where it was 7-8 days to get a test result back. And JAX was doing 24-hour turnaround time. So for Maine, what that looked like is the specimens got picked up in Maine, got by courier, were taken down to Connecticut, and then the test results from the time when they arrived, which is usually about 1:30 in the morning, within 24 hours, the test results came back. So basically for all of the Maine facilities that have been working with us, it's about 48 hours, which was significantly better than anything that anybody else was able to accomplish. So in addition to testing within the state of Maine, the other thing that we did is, and this was super important to the actual research into the vaccine and research into different treatments. We talked a little bit about models, about mice. There wasn't a good mouse model available at the beginning of the pandemic. And by a good mouse model, I mean a model that manifests the disease in the same way, sorry about that, in the same way that human beings actually acquire the disease, in the way that it manifests itself, and actually in the way as a model to be able to test drugs and even a vaccine. So one of the things that JAX is an expert at is mice, and in creating specific mouse models that have very specific genetic recipe, right? So we brought the mouse model from another organization into the Jackson laboratory, and it was a model that had been used previously for the first SARS epidemic, but had never actually been bred at a large scale. So in a matter of months, we brought that colony of mice up and began selling those mice, distributing them to multiple organizations, pharmaceutical companies, research institutions, and we're still doing the same thing with that model. So it really helped advance the discovery of vaccines, the discovery of drug treatments for the folks that were struggling with COVID-19, because not everybody has the same reaction to COVID, as you likely know. The other thing that JAX did during the pandemic is we helped locally with something called the Hancock County COVID Response Team, or the task force. And basically, as you know, the state of Maine was pretty much closed to much traffic from tourism. And we worked really closely for the traffic that was able to come into the state. We worked really closely with businesses, with the school system, with the national park, to just help put in place protocols for for safety. We donated tests for businesses and their staff. And throughout all of this, with all of the partners that we worked with, because we had access to PPE and actually to swabs and to the media that the swab goes into after the test, the specimen is acquired, we were able to donate those to all of the folks that we were working with, and actually to folks that we weren't working with who were desperate to get their hands on them. And I have to say, in full disclosure, that I knew more about swabs and about Puritan than the average person, because my husband happens to work at Puritan. So it was a really nice connection for Jax and for folks in Maine that were collaborating with us. But the other final thing that we've been doing since December, which is really important, is one of our research scientists, his name's Ryan Toohey, has been working with the Maine CDC from the very beginning to test a certain percentage of the positive specimens that go into the Maine CDC. And he's actually doing whole genome sequencing on the virus and identifying variants of the virus and sharing that information back with the state. And when I last checked, Maine was actually leading in terms of the percentage of positives that were being sequenced. So I know the governor's quite proud of that fact, as is Jax. So I think that covers it, at least the view from 30,000 feet, how Jax was involved. And I will pass this on, I guess, back to Kate, unless you want to do
back to me. I know
questions.
I said we were going to do, I was going to not get in the way, but I can't help myself. I have one quick question before we get it to Noah.
Okay.
What is the testing that you were doing? The CLIA lab was talked about actually in one of our other forums. So folks can check that out on our YouTube channel. We should have the video up in the next week or two. So if you could just explain what the testing actually was.
So in
if
terms
it was
of
the spit test, like,
oh,
was
yes,
it the spit
okay,
test?
sure.
Like literally because the 48-hour turnaround time was huge back then, right? Like I remember what felt like, it feels like it was years and years ago, but everybody was like, 7 or 8 days, you might as well not have a test at all. So what was the testing that you were doing?
Right. So we started, like everybody, with a nasopharyngeal swab. And I don't know if anybody's ever watched a video or experienced a nasopharyngeal swab, but your nasal pharyngeal area is way back here. And I'll give you a little anecdote. My 8-year-old granddaughter had a nasopharyngeal swabbing, and she told her father on the way home in the car, in no uncertain terms, that she would rather die of COVID than have another one of those. So I think everybody that had to have what we call NP, nasopharyngeal swabbing, kind of, it's not something you wanted to do weekly or bi-weekly, which is what we were testing Jax employees bi-weekly, right? So we quickly moved to, everybody did move to other ways to collect the specimen, right? And we moved to an anterior nares. So an anterior nares swabbing, if you haven't had a COVID test, the swab goes in to your nostril up about to here, goes around 8 times on each side, and then it goes into the media, that's the preservative, and then away it goes to us. But there were also, I know the University of Maine, on some of the remote campuses, they used Vault, which is a vendor, and they did the saliva test. But the saliva test, and we were able to do saliva tests, we could receive those, but it became, it's difficult because it takes like 10 or 15 minutes to get a saliva test, to get all the bubbles out of it. It's just a lot longer process, more labor intensive, et cetera. And an AN swabbing, especially once you get used to it, you've had it 2 or 3 times, it's very quick. And with guidance, you can actually do an AN swab specimen collection yourself. And we ended up doing that at Jax. And then once the specimen gets to our CLIA lab in Connecticut, it's a PCR test. So we are actually testing for the presence of the virus, as opposed to some folks are doing antibody tests, like the rapid tests. They're actually testing to see, do you have antibodies? Have you either been exposed, or do you have the virus now, and your immune system's creating antibodies to fight that? So we were testing for the presence of the virus, as opposed to for the presence of an immune response to the virus.
Great. If you have questions on public health, I have more, but I'm going to save them. So thank you, LuAnn. And we will pass this off to Noah. Noah, the floor is yours, and we will get out of the way.
Thank you, LuAnn. That was great. Thank you, Kate, for inviting me. And I'm going to share my screen, and we'll get right into this. And I've titled this, as you can see, medical ethics, practical reality, public health, and personal risk, because I think these are the things that are at tension and that you see debated in the context of vaccine distribution in Maine and across the country. And you know, ethics is always about tension between two good values, it's especially manifest in this context. So the Advisory Committee on Immunization Practices developed ethical principles to guide vaccine distribution prior to the approval of the vaccines that we have right now. So this was published in the MMWR, Morbidity and Mortality Weekly report in late November of 2020, and gave, you know, ethical principles that might guide distribution of vaccines. This wasn't the only resource available. Lots of institutions created papers on what ethical distribution of vaccine in this country and around the world might look like. Johns Hopkins had a group that included Ezekiel Emanuel that was quite interesting, a quite interesting framing of this. It's been interesting to see how, you know, when those principles get put up against the practical reality of vaccine distribution in a country like the US, how things change. So these were the 4 guiding principles that this group recommended: maximizing benefit and minimizing harm. Hard to argue with that. Promoting a just approach to distribution, using distribution to mitigate health inequities, and a transparent process so that the public understood the rationale behind the decisions that would get made in the distribution of vaccine. So to explicate these a little further on maximizing benefit and minimizing harm, these are the things that they called out specifically. You know, identify what groups are at highest risk for disease, hospitalization, and death. And, you know, one of the key groups is by age, especially people 70 and older. There's a rapidly escalating risk for hospitalization and death with COVID infection. So that was easy. And the CDC lists a number of chronic conditions that put people at greater risk. Obesity is one of them for sure. And people in certain circumstances, for instance, congregate living, where the disease can be spread quite readily. And unfortunately, people who live in congregate living situations often have other conditions such as age or chronic disease burden that put them at additional risk. What groups are essential to COVID-19 response? So everybody agreed that frontline healthcare workers were at the front of that line, and frontline healthcare workers benefited from that designation, were the first recipients of this vaccine once emergency use authorization was granted. But there are lots of other, you know, people who could be considered essential. The Biden administration decided that teachers were essential, and school staff and childcare professionals, and it's a totally reasonable decision. Food chain workers, you know, are essential frontline workers, et cetera. Public safety. How should they be considered? What groups are essential to maintaining critical functions of society? You know, the power grid and healthcare delivery system and food delivery system, and you know, all of that. So, and what are the important characteristics of these groups that might inform the magnitude of benefit based on the amount of vaccine available or its characteristics? So this manifests itself with the Pfizer vaccine, which was the first to be approved for use, because of, especially early on, the extreme cold storage and transportation chain complications that are necessary, the limited availability of that cold storage capacity once you get out of urban centers and healthcare, tertiary healthcare centers. So getting, you know, Pfizer vaccine, especially initially, into Jackman, Maine, was going to be a challenging process. So that's an example of the kind of thing that might have been covered by this last bullet point. Promoting justice. Does the allocation plan, distribution plan, result in fair and equitable access of the vaccine for all groups? I think we've all seen examples of failure in this regard. You know, for instance, we've heard about in the Miami area, wealthy people sort of getting access to the vaccine potentially through political donations? How do characteristics of the vaccine and logistical considerations affect fair access? The Pfizer vaccine, again, is a great example of that. The Johnson & Johnson vaccine may be an opposite example of that, where it's a very effective and very safe vaccine that only requires one dose and doesn't require all the cold storage. And so it makes a lot of sense for a lot of settings. And because it's single dose, removes some of the complication of follow-up vaccine and confers immunity 3 to 4 weeks earlier than 3 weeks earlier than Pfizer will, and 4 weeks earlier than Moderna will. And that's important for both personal and public health considerations. And does allocation planning include input from groups who are disproportionately affected by COVID-19? So do they have a voice in the decision-making around all of this? And I think we heard in Maine that people who suffered disproportionately severe impact from COVID, especially new Mainers and people of color in Maine, did not feel that they had an adequate voice in the initial planning and distribution of vaccine. In mitigating health inequities, does it identify and address barriers to vaccination? We're all still working on this: transportation, communication, internet access, comfort with using the internet for gaining access to appointments, etc. Does the allocation plan contribute to a reduction in health disparities? It's interesting that this publication did not call out specifically disparities by race, but racial disparities in all healthcare outcomes and in healthcare access in this country are the biggest persistent disparity that we see in almost every aspect of healthcare. And it's certainly been true in terms of both the impact of the disease from COVID-19 and the access to vaccine and vaccine hesitancy. What health inequities might inadvertently result from the allocation plan, and we don't want to exacerbate things, and what interventions can remove or reduce them? And is there a mechanism for timely assessment of coverage among groups experiencing disadvantage and course correction if needed? And I think we've started to see some course correction, although I think lots of people would argue not enough. And then promoting transparency. Does the development plan for allocation include diverse input? This is sort of redundant of a prior point in a prior bullet. Are they evidence-based and publicly available? Is the plan clear about what is known and unknown? I think Dr. Shah and the Maine CDC have been exceptionally good at both being transparent and at making clear what is known and what is unknown and how those are considered in the distribution process. What's the process for the revision of the allocation plans and mechanisms for reporting demographic data? That's still, I would say, imperfect in Maine. They're working on it, and it's getting better. And you can now see on the Maine vaccination dashboard distribution of vaccine by demographic data, much more than just age. So that's all I have for slides. I'm going to stop my share now and talk briefly about how we've gone about allocation in Maine and some of the nuances around that. So I think everybody's now aware that the Maine CDC and the Administration and Department of Human Services decided that in Maine, the most impactful approach would be based on age, and that because age, especially in the elderly, age is such a high risk factor for complications, but more appropriately or more relevant, that the utter lack of a meaningful public health infrastructure would make any other prioritization so labor intensive that it would slow down the distribution of vaccine to the extent that it would cause potentially more harm than good when you're talking about public health. When we talk about individual health, of course, we'd like to reach early on the 47-year-old with lots of risk factors as opposed to the 70-year-old with no health problems. But the logistics of that without a public health infrastructure and without access to the information about individual health that would come from, for instance, electronic health records that were entirely interoperable, able to communicate with each other, which none of them are, is a big barrier. So they chose age, and the mass vaccination sites and other efforts to do that make a lot of sense in that regard. Going into the nursing facilities for congregate living early on to protect the most vulnerable and where we'd had the most significant and harmful outbreaks made a lot of sense. And as they gained access to more vaccine, the guidance behind those became more clear about, when you could give vaccine to people who fell outside of those ranges, which is essentially to avoid wasting vaccine, we're allowed to go outside of those guidances. All of this, of course, followed first the immunization of frontline healthcare workers and first responders. The mass vaccination sites, there's no question, are going to be the most important and most impactful way of getting vaccine to enough people to get up to more rapidly approach herd immunity in this state and across the country. But they're not the full answer in a rural state like Maine. And so the vaccines that have been provided to other entities like us at PCHC allow us to go at this in a slightly different way. So at PCHC, initially we were receiving a couple hundred vaccines from the state each week. Now we have access as a federally qualified health center to direct shipment of vaccine from HRSA, from the federal government. And we anticipate in the coming weeks that we had been getting about 1,200 a week. We think we'll get more than that in the coming weeks. And our approach has been both for our own patients within the age groups, following the state's guidelines on age, we're able to, using our own data, to prioritize people by their risk. So we started with people over 70 who had 3 or more chronic diseases that put them at greatest risk, worked through that list, then 2 or more than 1 plus obesity. And parallel to that process, in each age group have identified our patients who are Black, Indigenous, or people of color, because they are so disproportionately impacted by this pandemic and have suffered such historical health and healthcare access inequities that as a matter of equity, we've included them as priority people for vaccine among our own patients. And then we've used some of our vaccine supply to help smaller healthcare organizations who can't get their own vaccine to immunize their frontline healthcare workers. We've used it once teachers and staff became priorities to help some school systems do focused vaccination for their employees. And we've also gone outside of our own patient population to vulnerable populations in congregate living situations that aren't nursing homes and didn't qualify for that first round of vaccinations, in senior and subsidized housing, going again by the age groups, and in going into organizations that might help overcome vaccine hesitancy. So we worked with a church to give vaccine on site at the church for people in their community, including their church members, but others who met the age criteria, who might feel more comfortable or safer doing it in a familiar environment. We're going to continue to do that work with religious organizations and others to try to overcome vaccine hesitancy by having people they trust involved in the process in a site with which they're familiar and in which they're comfortable. We're also providing educational sessions for the public through Facebook Live events and in other forums to answer people's questions about vaccine, because people are understandably concerned about safety, concerned about how this might impact their lives, have very practical considerations like, can they afford to miss a couple of days of work if they get a bad adverse effect from the vaccine, or even mild symptoms, but symptoms that mimic COVID and therefore would preclude them from going to work. So we want to help people with all of that decision making as well. And then lastly, we've distributed vaccine we have a site in Jackman, so we continue to distribute vaccine to Jackman to try and make it easier for folks who are in a community like that to access vaccine easily, whether they're our patients or not. We do the same thing in Waldo County through our practice in Belfast. And we're part of a consortium federally qualified health centers and smaller hospitals who are working to collaborate to distribute vaccine as well into more rural areas to people who might be challenged coming to the Cross Center, for instance, for a mass vaccination site. A lot of it's made easier now by the increasing availability of vaccines in pharmacies and other settings in people's own communities. And I'll close by saying it looks very promising that in April, the state's supply of vaccine may increase dramatically. And we're all hopeful about that. It looks very promising. And as we've seen throughout the vaccine effort, the dates for which we initially think will advance to the next group keep getting moved up. I even think it's possible that the opening to all Mainers could, I have no inside information on this, but I think it could move up earlier than April 19th, because when we see across the state, I know when the Maine CDC and the governor and the commissioner of the Department of Health and Human Services see that the Cross Center, for instance, last weekend had unfilled slots for people 60 and older, that's a cue to lower the age. That's a cue to expand the denominator. And I think that, that with increasing supply of vaccine, it's possible that those dates will get shifted once more. But even if they don't, April 19th now is a pretty promising date for people 16 and older to all be able to start to access vaccine. And I think it will get easier and easier to access vaccine as well. And so I'll stop there.
That was fantastic, both of you. I'm going to let folks, if you've got questions, throw them in the chats. I have a million, so I can easily take up the time, but I will cede my questions if other people have them. But I do want to circle back to at least one thing that you said, LuAnn, and we've spoken about this in the past as well. I know that Jackson Laboratory worked with not just the universities that you mentioned, but also school systems and school districts. And that is still a critical piece. I think testing going forward is still going to be really important. So could you talk a little bit about what you've been doing with kind of the K through 12 audience of people?
So the big initiative that we had, which was very early on in the pandemic, Jax has a fantastic, our staff is awesome. We have a really amazing facilities group, and it was in an effort to make sure that Jax employees stayed safe, but that Jax business continued, right, to the research, the production, all the support services for that, the education. We very quickly de-densified the campus, so were only critical employees that needed to be on campus to get their job done did that. And so our facilities team swung into, it was amazing to watch between the cleaning and the de-densification and the, how do you make sure people are socially distanced, et cetera. They put together an amazing plan. And we just had the resources to do that. And so what we did, it started with the superintendent in Bar Harbor. But what we ended up doing is inviting all of the superintendents for all of the schools in the entire state of Maine to join us for, basically it was a seminar. All of our experts were in our auditorium seated in the front. It was a WebEx. We had all the presentation materials, each of the area expertise. So our HR department, our facilities department, our research folks, Ed and our scientific director in Maine did a presentation on the virus, what it is, how it spreads, what we know about it, what we don't know about it. All of the things that Noah talked about in terms of, just from a public health perspective. And we had all of that available to them. I want to say it was 2 hours long. And obviously not every single superintendent joined us, but there were dozens of them. Maybe more than 100 actually attended, and the questions just went on and on and on. And then we shared the materials after the fact. And so basically, it was everything that we had learned about cleaning, right? In each of the offices, in each of the spaces, about and facilities cleaning, about adaptations that we had to make to the space to make sure people that had to be in offices together were able to be safe. It was basically a comprehensive package, like a book. Here, you guys take this. This is what we know about best practices at this point in time. We had digested everything that came out of the CDC because all of that, there was so much information and it was pretty dense and it was in lots of different locations. And so we basically put a package together and shared it broadly. We had videos that were on our public website that were available. All you had to do was jump on there, click, watch, you know, and implement. So,
And that was in preparation for the school year.
That was
like starting 2021, right? So people could feel comfortable that they could actually figure out a way to have some kids in the classroom.
Actually, that occurred. So when it was in 2020, months into the pandemic, and I'm trying to remember. God, so much as time has passed and so many things. It may have been in the summer of 2020 when we weren't sure whether people were going to be going back to school or not, while they were preparing to do just that, right? So, and some school systems did go back to school. I mean, my grandchildren have been in school in Glenburn since the end of August. So it depended on, you know, how school systems responded, what their ability to actually implement the plans that were being, you know, the information being sent out by the CDC and other experts.
Super helpful. Noah, we have a question from the audience for you. Can you talk a little bit about the waste lists? So waste is in quotes at vaccination sites. Are there a lot of missed appointments or leftover vaccines, and should people who are not eligible for the vaccine get on those lists? And if so, how do you go about it?
Yeah, so the concern about waste is that once you puncture a vial, you have 6 hours to use everything that's in that vial. In addition, most of the time we're able to get extra doses out of vials. At PCHC, we've been reliably able to get 2 extra doses per vial. So we plan on that now, but not everybody is able to plan on that. So once you puncture a vial, either because people haven't showed up at the end of the day, or because you end up with an odd number of people, you may end up with a vial that has extra doses, or in a large site, many vials that have doses that will go unused if not given within 6 hours. And so that's when they start working through. The guidance is that among the people you can consider first are people who are volunteering at that injection site. But even they should be prioritized by age and risk factors. So you'd start with, you know, with right now people over 50 who are volunteering. And if you can't use it up that way, you'd go to younger people or people with risk factors for more severe COVID disease. So the answer is yes. If you're able to get on wait lists, even if you're not in the age range, you might get access to a vaccine. It varies from site to site, even from system to system. So I know some Walgreens stores, for instance, do have a way of signing up to be on their waste list, and others don't. And so I think you can look at the vaccination sites in pharmacies and the mass vaccination sites, especially in areas to which you could travel on short notice, and just call and ask how to get put on their waste list, and do it in that manner. There is, and if it's a 2-dose vaccine that you're offered, and I would take whatever vaccine they offer. I have no concerns about any of the 3 vaccines being better or not as good as the others. But if it's a 2-dose vaccine you're offered, once you get the first one, then you will have access to a second dose in the right time frame. That's been an ongoing commitment from the Maine CDC, and in our experience, that's been they fulfilled that commitment. So yeah, it's worth doing. And mobility matters in getting access. Communication matters, which unfortunately means, well, maybe fortunately, that younger, more mobile people are probably more apt to get these waste doses than older, less mobile people. But older people now, people 50 and over have the ability to get appointments for vaccine now anyway.
I know, I got my first shot yesterday. I've never been so happy to be.
That's
My
great.
8-year-old self can't believe how excited my 50+ self was to get a shot.
I felt the same way.
2 other quick questions while we were talking about them. So LuAnn, you said that Maine leads the country, which is a phrase that I say often and love to say, but with looking for variants. And this will slide into a little bit to what you had mentioned, Noah, about the different vaccines and efficacy. But do you have any idea how many variants have been found? And is there any, and I'm putting you on the spot. I know you may
That's
not know,
okay.
I'm
No,
just
no,
curious.
I talk about this every morning, but
Okay.
I should have,
Just a general one. And then my understanding has been, and I know that we will get into this in detail next week with our specific COVID vaccine forum. Is there any sense that either one of you have for how the current vaccines have been dealing with those variants?
so Noah's going to have a lot more to say about this than I will. So I will say, I believe, and I can't speak. So when I get a report, we talk every morning at 8 o'clock in the CLIA lab. The information is combined, so we're not separating necessarily the where these variants are being identified. But so obviously Connecticut's a much larger population. We have identified 4 or 5 different variants that are present in that population. I know that there are multiple variants in Maine. I don't know, and when I say we're leading, I don't mean necessarily in the number of variants we've identified, but in sequencing positive specimens in search of
Right.
the variants.
No,
right?
I knew that. I knew you didn't. I
Yes.
didn't mean that we were leading in the variants.
No,
but
I just
in the
wanted to make
actual-
sure, because people
Thank
are
you.
very, very worried about variants,
Yes.
right? Very,
Excellent
very,
point.
very-
Thank you.
okay. So, and then no one will know more about, what does that mean? That we're identifying variants. I mean, viruses, they do what they do, right?
Right. Viruses are mutating continuously, and the longer a virus is allowed to circulate widely, like COVID has been, it's not been long in the big view of things, but the longer we go without controlling this pandemic, the more potential for additional mutations that are meaningful. So most of the mutations aren't meaningful, but once in a while, those arise that are harmful, like what's known as the South African or the UK or the Brazilian variants that we're all concerned about now. So the UK variant, for instance, is more transmissible, and the South African and Brazilian variants we're concerned might cause more severe disease. The Johnson & Johnson vaccine, people are concerned about, its lower effectiveness in the mid-60s reported worldwide, but in the mid-70s in the US. But it was tested at a different time when there was more disease and when the variants were already present. And we don't know what Moderna and Pfizer would have looked like if it had been tested at the same time. And I think the important thing to know about the Johnson & Johnson vaccine is that it's 100% effective for severe disease, hospitalization, and death. And preliminary study out of Israel indicates that, it may very well be that these vaccines also prevent us from having an infection at a level that allows us to transmit it to other people. More study has to be done on that, but it's promising looking. I do think that there's evidence that at least against the UK variant, that we can be reasonably hopeful that these vaccines are going to be very effective. And I think there's evidence with the South African variant as well. I'm not as sure about the Brazilian variant, but I think that we can hope that there will be, without as much evidence to support that hope as with the other two. And I think I think most people expect that we're going to need to have boosters to this vaccine to maintain meaningful immunity and prevent the emergence of a new pandemic from this virus or its variants. And meanwhile, the race is to try to get to herd immunity in this country and around the world, because that's how you're actually going to end the pandemic. before too many more of these harmful variants develop, or variants develop that are truly resistant to the vaccines that we've developed so far.
And we have time for one more question. I think this probably mostly applies to Jackson Laboratory. Where did you receive funding for the work that you've done? Because you've done a lot of work.
So, you know, I'd have to, that question, I'd have to pick at that question just a little bit. Much of the, so for instance, all of the sequencing work that's been done so far, we're hoping that to get into a contractual arrangement, but since the pandemic started, basically, Dr. Tui's lab, he with his startup package, he has absorbed all those costs. He has not been paid for that work at all. With respect to the donation of all of the swabs and the media and all of that stuff, Jack's absorbed that cost as well. And then for the startup costs for the equipment, et cetera, you know, that we used to get the CLIA lab, you know, by the Thermo Fisher and all of that stuff, we also absorbed that. And then we began charging for the testing, but we were very competitive and still are with the cost of our tests. Hope that helps.
Yeah, I think it's fair to say that there hasn't been funding across the board, and we're still trying to figure it all out. I mean, that's not just true for Jack's, that's true for everybody. And Noah pointed out earlier, one question I had was, you know, the utter lack of public health infrastructure, and we're going to have to fix that one way or the other, or just have this space us again. That's my little soapbox. I probably shouldn't get on there for, but it's very clear to me that the infrastructure is not there, and you have to do funding to get it.
I will tell you, because from the very beginning, I was part of a team of 3 colleagues who we were really responsible for making sure, just figuring out this whole testing thing. And it seems so easy now that it's been done, right? But it wasn't easy. And in California and in Maine and in Connecticut, if I have a single lesson that I could walk away from with respect to this pandemic, it's that the IT infrastructure, the ability to be able to communicate data in a confidential way, that was the biggest nut to crack. And you know, I just blew my mind that within the state of Maine, there's no single way for hospitals, for clinicians, for test sites to communicate data. How do you get a positive test result? How do you send the CDC the information? It was mind-boggling to me.
I'm going to hazard a guess, Maine is not alone in that.
No, you would be absolutely right. I mean, it would be, if the federal government could figure out a way that, you know, and I know there's lots of reasons that nobody wants to do this, but next pandemic, we have something in place. You just pull the trigger and there's an ability to, you know, like I'm going to date myself, but I can remember when watching TV at midnight, the emergency broadcast system thing would come on, right? If we could do something like that in a crisis, it would be great.
Yeah, and I would argue, again, we don't need it just for a pandemic. It would be helpful just in many, many other ways.
Many other ways.
Yes.
All right. With that, I am going to do a quick screen share here. So next week is our very last session. And I don't know how to do screen sharing either, even though I've been doing this. Super excited about this. I've heard Elizabeth give 2 different versions of this talk just since February. She has done an extraordinary job researching and keeping tabs on all the different vaccines out there and how they work with the viruses. So there were a couple of questions in the chat about that. I know, Laura, you touched on them a little bit. If you want a deep dive, I cannot recommend joining us. I cannot recommend enough joining us for next week. All your questions will be answered about efficacy, what it means, what does efficiency mean, how do the different vaccines work. She does a really wonderful job, and that will do it for us with regards to COVID in Maine. And my hope is after this March is finished, we can circle back, take a breath, and start talking about all the great science that happens in Maine on a regular basis, including the work that you're all doing. Very, very grateful again for your time. I know you're both swamped. When we are all able to get back together again, we're going to have some type of science party. I don't, even beyond the festival, I'm not entirely sure what it is, but it will be a lot of fun. And I encourage everyone who's on here to join us, and you all as well. Thank you so much.
Thank you,
Thank
Kate.
you.
Thank you, Noah. And thanks to everybody for jumping on and listening. Appreciate it.